everyone. Thank you for joining us here today at the Muscular Dystrophy Association, our webinar on updates and emerging questions in DMD. And today I am excited to introduce everyone to our two presenters. We have Dr. Steve Chrzanowski and Dr. Leslie Hayes. Steve, and I will let you go ahead and kick it off.
Yeah, so thank you so much for the opportunity to speak today. Between Dr. Hayes and myself, we're going to be talking a little bit about the timeline of Duchenne muscular dystrophy, how we've gotten to where we are today, and the current treatments that there are, and where we're going forward from here. So next slide, please. Next slide. So we'll use this timeline as our roadmap to lead us through today. As many are aware, Duchenne was first clinically identified as late as the 1800s, though as with disorders of this era, it was entirely on a clinical basis. In 1961, the first biomarker, the activity of CK, creatine kinase, was identified as a nonspecific marker of the disease. In 86, 87, and 88, the dystrophin protein was identified, the gene was isolated, and steroids were recommended. And there was significant frustration for several decades, really until the 2016, when the first antisense oligonucleotide was approved by the FDA, with a subsequent windfall of other treatments, including a microdystrophin gene replacement and most recently an HDAC inhibitor. So we'll get into each of these topics as we dive through DMD's timeline. Next slide, please. And I'd like to take us all the way back to the 1800s to this book by Guillaume Benjamin Duchenne, who is the first person to clinically recognize, to identify, and publish on the findings of DMD. I've just screenshotted a couple photos from the book, and as you can see here, the clinical presentations then to now are really not that dissimilar. We see the hypotonic infant. We see what is the classic Gowers sign, Gowers maneuver, to walk oneself up their own body, the scoliosis that we see, and then in the last picture to the right, the pseudohypertrophic calves, the lordosis of the spine. And I always forget to say, please forgive the graphic nature of some of these images and the videos that we'll be showing, just as they were collected in a different time frame when it was more acceptable for this sort of thing. Next slide, please. And please, if you don't mind playing the videos as we chat. So I was able to capture and identify several videos taken. They were taken by a French neurologist in the 1910s. And what they do is very well, you can see what the clinical features of Duchenne is. In the first video, where the boy rises from a supine position, you can see the classic Gower sign, where he has to walk himself back and up his own torso because of the weakness that he has. We can start the next video, please. And in this next video, if you imagine this is 10 meters, this is what we would say today is the 10-meter walk-run, where you can see the boy kind of walking on his toes, the hypertrophy calves that he has, the curvature of his spine, and the waddling gait that he shows. And we'll look at the last video. And in this last video, I would call this today's equivalent of the 4-stair climb, where you can appreciate the proximal weakness of the large anti-gravity muscles, his glutes, his quads, and hamstrings, and he's got to almost yank himself to get up the stairs. And so I raise and show these videos not for the graphic shock and awe nature, but really to highlight that in some areas in the treatments that Dr. Hayes is going to talk about, we've come quite far, but in other areas such as biomarkers, outcome measures, we're using what we've been using over 100 years ago. And we're using these, if I may, seemingly archaic measures in these multi-million-dollar clinical trials that are ongoing. Next slide, please. So this will be the one basic pathophysiology slide that I show. So what we see here in blue is the dystrophin protein. When functional, dystrophin connects the intracellular contractile elements of muscle, that being actin, to this conglomeration of proteins, the dystrophin-associated glycoprotein complex, ultimately connecting to the extracellular matrix. You can think of it like the rebar in concrete, really providing stability. So in DMD, when it's not functional, we can see an absence of the dystrophin, an absence of all these proteins that should be localized to the sarcolemmal membrane, and it renders the muscle cell vulnerable to contraction-induced injuries, leading to this well-characterized inflammatory cascade of inflammation to lipid deposition to fibrotic replacement of the formerly functional muscle. Duchenne, as many people are aware, is caused by out-of-frame mutations to the DMD gene. It's found on the X chromosome, so therefore inherited in an autosomal recessive manner. And important and a reason for why treatments have been so hard to come up with. It's the largest gene in the body at 79 exons. It's about 2.4 megabases, and that's 0.1% of the entire human genome. So it's been hard to replicate that for treatments. Next slide, please. And so what we see clinically is, as I described, the proximal weakness greater than distal early on. Boys have delayed gross motor milestones. They can't keep up with their peers on the playground. They fall more frequently. By early teenage years, they're often non-ambulatory, requiring mobility assistive devices. And we remember that muscles throughout the body. It affects the diaphragm, so it's not uncommon that our boys who become men need non-invasive ventilatory support as they get old. These are not the biopsies of the individuals shown, but representative to really span the ages where you can see early on the large inflammation that's happening in the muscle to subsequently be replaced by lipid deposition and eventually scar tissue replacing it. Life expectancy is improving, and our boys are living to be men well into their 30s because of better cardiac and respiratory support. Next slide, please. And so we know that cardiomyopathies happen with Duchenne as cardiac muscle contains dystrophin. And this is clinically relevant. It results in arrhythmias, heart failure, and ultimately is a major contributor to morbidity and mortality. Presently, standard of care is to prophylactically utilize cardioprotective medications, though this wasn't always the case and was really controversial until recommendations came out in 2018. As you can see here in this figure, the red crosses are when prophylaxis was used, less than 10 years of age. And you can see with the Kaplan-Meier survival curve that survival is better if prophylactic cardiac medications are on board earlier. We use advanced imaging techniques, contrast, cardiac MRI with contrast as to identify myocardial fibrosis from the late gadolinium enhancement. And there's ongoing discussion and advocating for new ways to take care of heart failure. And it's hard to quantify specifically, but there's been what sounds like greater than 10 heart transplants actually for Duchenne patients of recent because these boys are living to be men with high quality of life in their advanced years. Next slide, please. And so beyond the heart, we know that the lungs are also affected and that pulmonary function is progressively impaired in Duchenne. Decreased pulmonary function is multifactorial. Obviously, there's the neuromuscular weakness, the decreased cough, impaired cough that this population has, but also other things that we have to consider, the scoliosis or constipation bloating that just limits how much the lungs can inflate. And not unlike other neuromuscular disorders, non-invasive ventilatory support prolongs survival in Duchenne. And we see that here, and we know that with steroids, pulmonary support is further prolonged by Dr. McDonald's work as shown here. Next slide, please. Dystrophin has a number of isoforms, several of which play contributory roles in neurodevelopment, helping neuronal migration during development of brains. And so it's not uncommon that our population also have neuropsychological disorders and symptoms, with not limited to, but including some of the things that we list here. So we'll go to the next slide, please. So, in summary, where we are today is that survival is improving, but we really don't have any game changers. In the Kaplan-Meier curve on the left, I've put a red line at the 50th percent survival. And as you can see, back in the 60s, survival was barely to the teens. And this is actually, I would say, outdated today, as boys are living well into men into their 30s, living longer and with really high quality of life. Next slide, please. And so now we'll segue into we've talked about the disease. We'll talk about how do we diagnose it and some of the recent work that I've been a part of with newborn screening. Next slide, please. So historically, historically, diagnosis was made entirely in clinical exam. This was before genes, before proteins were known, with typical myopathy features, proximal greater than distal weakness, neck flexion weakness, the large pseudohypertrophic calves, waddling gait, and such. Biopsy is still performed, but played a much more prominent role in years past. It's reserved these days for cases that are not entirely clear, for individuals that might fall on the intermediate DMD spectrum, or if there's confusing genetic testing. We still do it, but not as common as in the past. CK, as mentioned, was appreciated to be elevated in Duchenne in the 60s. It's not specific. It is reflective of any injury to muscle. So while it might be a good screen-in measure, it's not specific enough to be able to diagnose Duchenne. As any neuromuscular person should be aware of electromyography, I felt just obligated to include it, though we really do not use this at all for DMD diagnosis. We get really not specific features, small irritable polyphasic motor units with early recruitment. It's really not that helpful. And then I want to highlight molecular testing. So by molecular testing, I mean genetic testing. And this is critical for diagnosis and workup in the current time, because many of the treatments that Dr. Hayes is going to be talking about are mutation specific. And so it's critical and necessary for us to know what mutation is causing one's Duchenne. Newborn screening, as everyone is aware, there's been a huge push for newborn screening for Duchenne with a lot of questions and a lot of data that still needs to be collected. But our group at the Brigham played a not insignificant role with moving forward to get Massachusetts as one of the states that's recommending newborn screening for Duchenne. And we'll talk about our study in the forthcoming slides. Next slide, please. And so what we see here are biopsies of individuals unaffected and affected by Duchenne with the H&E, and then immunohistochemistry looking at specifically dystrophin. So in the, healthy normal biopsies, you can see a beautiful looking muscle with crisp angulated fibers of similar sizes with peripherally located nuclei, and then really nice uptake and staining of the dystrophin in a subsarcolemmal pattern throughout. And compare that to DMD, it's not specific, but we really see just a really inflamed, irritated, nasty looking muscle where there's fibers of different sizes indicating ongoing necrosis and regeneration. There's centralized nuclei. You can appreciate the inflammatory infiltrate and the fibrosis that there is. And as confirmed with immunohistochemistry, we just don't see very much staining for dystrophin, confirming such a diagnosis. Next slide, please. So we'll get into biomarkers a little bit now. In the 60s, Okanaka and colleagues showed hypercikaemia in a number of myopathic greater than neuropathic disorders, with Duchenne being the most prominent, probably because of the sheer numbers. And later it's known, and we know today, that CK levels diminish with time in this population. The thought being that there's just less bulk of muscle that's able to be injured. And so with the decreasing muscle bulk, CK levels go down. Next slide, please. We'll transition to newborn screening because we do use CK for it. And so to be considered on the recommended uniform screening panel at the national level, a disease must meet several criteria. It must obviously be a serious enough disease for which it's known that Duchenne is a very difficult disease and serious enough. We have to have adequate treatments. And there was a real paucity of treatment until the last decade. And so it wasn't really even considered because we couldn't treat it other than nonspecific steroids. We have to be able to have an adequate assay, for which we now do have a good assay using CK, more stable than activity. And we have to have a pathway for being able to implement a plan upon identifying positive hits on newborn screening, which we do here. Next slide, please. And so despite DMD being sequenced in 88 and treatment with nonspecific steroids in 89, nothing happened for several decades. And because of that, as I said, newborn screening was not a thing. However, with the advent of some of these therapies, there's been a real push to do newborn screening. Ohio was the first state to recommend and is implementing it now, followed by New York, Minnesota, and ourselves in Massachusetts. Next slide, please. And one of the questions is, how exactly should we do newborn screening? The run-of-the-mill thought is that do CK testing as a sensitive screen-in test, followed by genetic testing, but you can see the variability even between states of how newborn screening is implemented. Next slide, please. And so what you can see here is that states have their own CK thresholds. They have their own timing. Different states collect their newborn screening blood spots at different times, and that impacts what CK level is done. And there's a number of ongoing studies, validation studies, and data that are being collected as to try to make this a little bit uniform, because this is a challenge that we're currently facing. Next slide, please. So I'm going to talk you through the study that we were a part of at my time at Boston Children's with Brigham and Women's Hospital. So between 2021 and 2024, we consented and enrolled about 17,000 babies, both males and females, into our study. There was a minority, which is actually pretty important, 6 subjects who had a dry blood spot but were unable to have CK testing done, but we were still able to run genetic testing on them. Our big question was, can we simplify the process for identifying dystrophinopathies with newborn screening? Can we do a 2-step process? And can we do it with the same blood spot that was collected in the nursery or the NICU and run genetic testing on that? And the thought being is that if we do a 2-step process like this, instead it requires a single poke that's already to be obtained with regular newborn screening. It doesn't require someone to reach out and have an additional poke on the baby. And so there's no additional ownership, and it's a way to prevent things from falling through the cracks and patients from going missing. So we asked, can we do CK followed by next-gen sequencing of DMD on that same dry blood spot? And the answer is overall yes. So of the 17,000 patients, about 97% immediately exited the pathway. Another differentiating part from our study from what others have done is that we use a very inclusive 97th percentile cutoff rather than other places that have done the 99.5 percentile. With the thought being, we wanted to see, do we need to have a more inclusive study, or is what's already being done adequate? We ran genetic testing on those that were deemed high risk with hyperCKemia, and not unexpectedly, the majority of individuals had normal DMD or non-pathogenic VUSs, so they exited the pathway, they were healthy. They were offered repeat CK testing, but the majority actually just opted to be clinically monitored by their pediatrician. We interestingly identified 5 pathogenic variants, all in females. There were no males identified with Duchenne, but 5 pathogenic variants were identified of that high-risk cohort that subsequently then followed up in the neuromuscular clinic. One of the female carriers that was identified was an individual who was unable to have her initial CK run of that delayed sample N equals 6 group, but because we had her dry blood spot, we could still run genetic testing on it, for which we did. Next slide, please. And so this is what our raw data looks like. In the state of Massachusetts, different than other places, our newborn screening is run from 24 hours to 48 hours. That's when the blood spots to be collected. And you can see the positive skew. I think it's just the nurses that want to collect the blood spot and get it out of the way earlier on. And then if you look at it, you can say it's diminishing over time. Next slide, please. And what we see here is overlaid the DMD carrier values. And as I mentioned, there's that 5th girl who only had genetic testing performed without an initial CK. And so we only have 4 values for the CK. Next slide, please. What I lay here is our study at the 97th percentile versus what was done elsewhere at the 99.5 percentile. And so what this means is that anything above those dashed lines goes for genetic testing. So we ran more genetic tests than the other studies, But I think also important to consider is that we captured 3 females who would have been otherwise missed if at the more stringent 99.5 percentile. Next slide, please. And we all know that other things contribute to hyper-CKemia, and so we just wanted to show that data. So we know that anything that might elevate CK in the babies, such as shoulder dystocia, use of instruments, low APGAR scores, contribute at different amounts to hyper-CKemia. Next slide. And with this research, just like most research, we have more questions than answers. The big question being, what is the optimal screening design? Is our more expensive, but I might argue straightforward 2-step protocol better because there's less gaps, less potential errors, less potential opportunities for patients to fall through the cracks than a more cost-effective 3-step model? And what should the cutoff threshold be for CK? Should it be more inclusive as ours, knowing that that's going to be more pricey? Or is it okay to have a more stringent criteria? What should genetic testing be? Should it be just DMD? Should it be a neuromuscular panel testing for several hundred neuromuscular disorders? Or maybe someday whole exome sequencing is going to be done. And then I say, is identifying female carriers, but identifying boys even at this age actionable? And one will argue that it's the ultimate equalizer in medical equity, being able to identify this disease 5 years earlier than the average diagnosis time to people who might have a hard time getting to the hospital, getting to medical care and such like that. But there's a lot of questions. Should we treat early? Is that going to be beneficial for the patients in the long term? And we just don't have that data just yet. And then how do we manage conditions that elevate CK that are not Duchenne? We're going to identify limb-girdle muscular dystrophies, other myopathies that we don't have treatments. And to think forward a little bit, we got to work with industries as to conduct trials in these younger patients. So how do we do that? What kind of biomarkers should we use in this population? So a lot of questions raised with a few answers. Next slide, please. So we're going to pivot here and talk about where we're going in the future. I think we've laid forth the groundwork of what Duchenne is, how it's diagnosed, and the clinical features. Next slide, please. And if you remember that molecular pathophysiology slide, there's a lot of targets. Dystrophin does a lot of things other than just scaffolding the muscle and stabilizing it during contraction. There's targets that we can look at: fibrosis, we can manage the heart function, muscle growth, mitochondrial targets, ischemia, inflammation. So we have a number of targets that we can approach, for which Dr. Hayes is going to talk about some of the FDA-approved treatments for the remainder of this talk. Next slide, please.
Great, thank you. Can you hear me okay? Just checking. All right. So I'm excited to talk to you guys about the disease-modifying therapies for Duchenne muscular dystrophy, and excited to report that there's actually a reasonable list of them. I'm primarily talking about sort of clinically available or approved therapies, and we'll sort of wrap up by talking about some future directions and things in development. Next slide. So to start with steroids. So steroids have been around as a treatment in DMD, going back to even observations in the 1970s, where people saw that boys with DMD had improved strength while being on steroids. Interestingly, even then in these sort of early descriptions, they noted that there was sort of an initial improvement in strength after starting what was used as prednisone at the time, followed by a sort of plateau of effect, and ultimately still decline in their strength, as is the natural history of the disease, although at a later sort of time point than those that are not on steroids. Prednisone has subsequently been studied in clinical trials and is really the foundation of treatment in DMD, and really was the only treatment, as sort of illustrated earlier, up until the last decade when things have really sort of exploded. Next slide. So now we have more than one steroid option. There are 3 that I'll talk about. Steroids in general likely work by multiple mechanisms, predominantly reducing the sort of inflammatory response that was shown, in that muscle biopsy slide earlier. And the inflammatory response kind of causes secondary injury in the dystrophic muscle, but steroids also may alter gene expression and they may improve some of the muscle repair mechanisms as well. The effect of steroids, and I'll focus primarily on prednisone to start, but ultimately studies have shown that the three of these are relatively comparable. Vamorolone is sort of the new kid on the block, and I think we have less experience with it, but the early studies suggest it's pretty similar. Steroids really, improve strength in boys with DMD. They prolong ambulation by around 2 to 3 years, and even have an effect sort of after ambulation is lost in upper extremity strength, cardiopulmonary disease. So in most cases, boys with Duchenne are on steroids lifelong once they're started, depending on their ability to tolerate the medication. And that gets to sort of the biggest challenge associated with steroids of all flavors, are the side effects. So, prednisone, as probably most of this audience is well aware of, has many side effects, some of which I listed here, but there are even more. And that really limits our, use and of this treatment, and is a huge cause of morbidity in our patient population. So there have been a lot of efforts to develop new steroids that have at least the same efficacy of prednisone, but hopefully reduce side effects. And that's led to sort of the approval of deflazacort and vamorolone. Next slide. So starting with deflazacort, which has been around for longer, and so we have more data on sort of the efficacy and the side effect profile. This is data from the 4DMD study, which is one of the larger sort of observational studies looking at prednisone versus deflazacort, and actually also an intermittent prednisone group in there. But sort of focused on the blue and yellow trends there, we saw that prednisone and deflazacort had similar efficacy. This is one measure. There were multiple others looked at. This is the rise from floor velocity, which you saw a nice video of earlier. Next slide. Also from the 4DMD study, there was an emphasis on comparing side effect profiles of these two treatments. And generally, they're pretty comparable. There are a few sort of things potentially where they diverge. One is in the area of weight gain, where potentially deflazacort has a little bit better profile in that regard. There were much higher rates of cataracts in patients with deflazacort, and so when we use that, we do have patients monitored by ophthalmology for that complication. There's other literature that suggests that there may be better effects on height. So, steroids in general reduce growth potential or height velocity, and potentially deflazacort does better in that area, and potentially a reduced fracture risk, but it's not sort of consistent across all the studies. Last comment I'll make about the height, because it also comes up when we think about vamorolone, where the data also suggests that it has less effect on the sort of the stunted growth that we see with steroids. It's really unclear whether that is beneficial for patients with Duchenne muscular dystrophy. Potentially the sort of short height and lower center of gravity and things like that may actually be beneficial for motor function. And so it's still yet to be seen whether that's truly helpful for our patients or not. Next slide. Okay. So, just back to the sort of three comparisons, I'll conclude by saying that despite steroids being, our foundation of treatment for decades, we still have a lot of variability across the country within clinical practice as to how to use steroids, what age to start steroids, what regimen to use, which one to choose of these three options now. And you'll see probably that field evolve as well when we think about implementing other treatments that I'll talk about now. So next slide. Okay, so givinostat is also a very newly approved oral daily medication, just approved by the FDA this past year. It's an HDAC inhibitor, which is a class of medications that are being studied or used in sort of multiple conditions. The mechanism that HDAC inhibition works in DMD, illustrated here, although it's more for the pretty graphic than for you to necessarily get into the weeds. But the point is it's multifactorial, and the overall aim is to sort of counteract that dystrophic or destructive process that's occurring in the muscles in the setting of dystrophin deficiency. So likely the HDAC inhibitors work by promoting regeneration in muscle, reducing inflammatory effects, inhibiting the production of that connective tissue and fat cells illustrated earlier in the histology slides, and promoting differentiation into new muscle fibers. Next slide. So how does this work clinically? So as I said, it's a fairly new treatment that our experience with is limited, but the clinical trial, so this is the phase 3 clinical trial that led to the approval of this treatment, showed improvement in multiple areas of motor function or measurements of motor function. The 4-stair climb, which again, we saw a nice video of what is involved, is illustrated on the bottom, and that was the primary outcome measure in the phase 3 clinical trial. As you'll see, it shows that patients on givinostat were able to maintain the speed at which they ascend 4 stairs better than those who were not on givinostat. I will note that all these patients were on steroids, so this is, using givinostat in addition to steroids, not in replacement of, so it'd be the combination of the two. Thanks. All right, so exon skipping is the next treatment I'll talk about. And to explain exon skipping, I'll first draw your attention to the upper left, the green schematic there. So this is an illustration of the 79 exons of the DMD gene. And Steve referenced earlier, in-frame versus out-of-frame mutations. So in dystrophinopathies generally, meaning conditions that are caused by abnormalities in the DMD gene, there are the most common sort of phenotype is Duchenne muscular dystrophy, and that is associated with out-of-frame mutations, or deletions, I should say, where whether it's one or multiple exons lead to sort of a mismatch of the adjoining exons. So you'll see sort of in the bottom right, in the scenario of deletion of exon C, the B and D, which are the neighboring exons, don't kind of conjoin, the puzzle piece doesn't fit, and it leads to absent dystrophin. In another dystrophinopathy, which is Becker muscular dystrophy, which is a milder phenotype where boys ambulate well into adulthood, the deletions that we see are in exons where the two sort of sides of the neighboring exons come together nicely and are in frame, and therefore produce some dystrophin and therefore a milder phenotype. So the goal of exon skipping is to sort of harness that natural variability and create a Becker muscular dystrophy-like genotype. So if you look at like the bottom right, we use an ASO to actually extend the deletion, but create it into an in-frame deletion so that in this sort of theoretical scenario here, A and D can conjoin nicely and create some dystrophin. So a really sort of like elegant use of something that was already naturally occurring. Next slide. And there are 4 FDA-approved products that use this strategy. The first one approved in 2016. They target 3 different exons, which are in sort of the hotspot region of the DMD gene, where we see a lot of exon deletions commonly. Although even when you add these up cumulatively, it's still only is in a sort of a viable treatment for up to 30% of boys with DMD. So it's not sort of universally applicable. These treatments were approved really based on some preliminary biomarker data. And you'll see this as a common theme as we talk about some of the other treatments as well, which is in the early studies, they showed that these treatments increased dystrophin production in a muscle or expression in a muscle biopsy. So typically a Duchenne muscular dystrophy biopsy has like 0% dystrophin. And when given this treatment, there was an increase, although a modest increase, as you'll see here. It sort of was unclear for a time whether this would translate into clinical benefit. And I think that, the maybe jury's still out a little bit as to the clinical benefit seen by these treatments. I think in practice, there's a lot of variation. There definitely are some boys who seem to be benefiting from it and others that aren't. And the clinical trials similarly haven't shown a robust clinical benefit, but given sort of the nature of the treatment, I think there is a lot to build upon, and we'll talk a little bit about how potentially modifications to these could be really effective. The other challenge with, or sort of downside of this treatment, is the burden of administering it. So as you'll see here, these are all weekly IV infusions. So boys typically need a port. It's, that comes with its own set of complications. They receive this treatment weekly. So, there is that burden as well. All right, next slide. So I'm going to briefly talk about ataluren, which is actually not FDA approved, but it is clinically available in Europe because it has had a conditional approval with the EMA, although that's currently sort of under review and may be revoked in the near future. But ataluren works for boys who have a nonsense mutation in DMD that leads to a premature stop codon and a truncated protein. So a different sort of genotype that we do see in about 13% of DMD boys. Ataluren sort of binds and allows for the ribosomes to read through that stop codon in the mRNA and produce a fuller length dystrophin. Similar story, I would say, to exon skipping, which is it was initially approved, in this case in the EMA. It was never approved in the US, but approved in Europe by the EMA based on preliminary data using a biomarker being dystrophin expression. And then subsequent studies were conducted, and unfortunately the phase 3 clinical trial did not meet its primary endpoint, which was the 6-minute walk test. So based on sort of that, the EMA has been reviewing and has recommended not to continue that approval, unfortunately. But we'll see, it's still in review. Next slide. Although because it has been clinically available in Europe, they've been collecting data through a registry. So on the right, you'll see data. In the blue is sort of the natural history study, and in the red is the STRIDE registry of patients that are on ataluren. And it does seem to suggest that there is a benefit for patients in prolonging ambulation. So I think there's still a lot of unknowns about how effective this really is, and if this would be available for that admittedly small set of DMD patients that would benefit. All right, next slide. Okay. So the next treatment I'll talk about is gene replacement therapy. And while there is one currently FDA approved therapy, and I'll talk about that in a little more detail, I'm going to focus first on sort of the right side and talk about gene replacement therapy in general. Gene replacement therapy in DMD uses a platform, which is an AAV-based product. It involves an AAV capsid, which is sort of the packaging, and inside is the promoter and the microdystrophin transgene. This is not a sort of novel platform. It's used in other conditions, and notably like Zolgensma for SMA is a similar concept. One of the biggest differences in DMD is that the DMD gene is extremely large and exceeds the capacity of an AAV capsid, or at least of a single AAV capsid. And so we've had to make modifications in order to create what is now being referred to as a microdystrophin transgene. The microdystrophin transgene includes different essential components that we think are the most important ones, and allows it to be within the size limitations of the AAV capsid. While there is one FDA approved product, there are also 3 others, I guess, in clinical trials and in development. And you'll see sort of the bottom right there are 3 different microdystrophins using all slight variations of what's included in that transgene. Interestingly, the way in which we decided on what components to include is actually based on patients. So there are individuals out there who have these really large deletions in DMD, yet have relatively mild phenotypes. And that really informed us as to what parts of the DMD gene or the dystrophin protein are most essential for function. So that's one area where there is some variability between the different gene therapy products. Also, the different products in development have slightly different promoters and different AAV capsids. So while this sort of category of treatments is all under the same platform and under the same sort of framework, they do each have some variability that may lead to differences in efficacy and safety, but we'll learn about that in the coming years. These are all one-time IV infusions, which the durability is still unknown. The one currently approved product is ELEVIDYS, which is the generic name is listed there, and I won't attempt to pronounce. It was received conditional approval in June of 2023 for boys with DMD that were 3 or 4 years of age. And then a year later in 2024, the label was expanded to include most boys with Duchenne that are 4 years of age or older. And there are some that are excluded based on certain genotypes, and then also based on AAV antibody status. So in order to receive this AAV product or any AAV product, the patient needs to not have existing antibodies from sort of natural immunity, because that would affect both the safety and the efficacy of the treatment. So that does limit its sort of wide use in the population, particularly when we think about older boys who have had more exposures. That initial approval in 2023 was really based also on an increase in dystrophin expression and some early clinical data that showed that particularly those younger boys were showing improvements in strength and function. And that was followed up by a phase 3 clinical trial. Next slide. So the EMBARK study was the sort of pivotal phase 3 trial that recently published results. And unfortunately, they did not demonstrate improvement in the primary endpoint. So the primary endpoint was something called the North Star Ambulatory Assessment, which is a standardized kind of composite motor score that's been used in Duchenne previously. And that's seen in kind of panel B over on the left. And you will see that boys that received ELEVIDYS did have improvements in that score, though not statistically significant when compared to the placebo group. And this was over a 1-year time frame. So I think it's still yet to be seen what a longer time frame would look like for these boys. And also some post hoc analysis did show that boys that were younger, so 4 and 5, had more benefit as compared to the older participants. And that makes sense in some ways when we think about other AAV or other gene therapy products in general, where earlier treatment is better. We did see that there were improvements in some of the secondary motor outcomes, and I've put a few illustrated here. So it was a little bit mixed as to which ones sort of achieve statistical significance or not. But in general, you do start to see some divergence, although it is not probably as large of a divergence as one would hope. Next slide. One of the other big challenges with AAV gene therapy, both sort of when we think about ELEVIDYS as well as the other products in development, is the adverse events that we see after infusion. In total, what we're mostly looking at are complications related to the immune system's response, either to the AAV capsid itself or to the transgene expression. You'll see here it's actually illustrated in sort of a timeline. Most of these complications we see in the months after receiving the infusion. These complications can range from things we've seen before in other AAV products like TMA, transaminitis, but also can involve serious liver failure, myositis, myocarditis. So multiple sort of complications that we are still learning how to manage adequately. All patients who receive at least ELEVIDYS are on an enhanced steroid regimen, so increased dose as compared to their baseline steroids in an effort to mitigate these effects. Although there are thoughts that potentially more intense immunomodulation, sort of along the lines of conditioning essentially, may help reduce these complications and even potentially improve efficacy and sort of delivery by reducing the host's immune system response. Some of the gene therapy products that are currently in clinical trials are using a much more sort of ramped up immunomodulation protocol, and that could potentially be applicable to all AAV products going forward. Next slide. So while the approval of gene therapy in DMD is a huge milestone, there are still a lot of questions, and maybe more questions than answers, as to where to go forward with this. There's still potential for better vectors than what we currently have that are safer and also more efficient at delivering the transgene. As I mentioned, can we enhance our immunomodulation to improve the safety and reduce sort of the neutralization of the therapy by our immune system? A lot of questions still exist around the durability of gene therapy, because it's relatively new, and muscle is a tissue that turns over. There's the problem of antibodies. So both in scenarios where boys have pre-existing antibodies from natural immunity, or in the scenario where there isn't sort of as robust durability as we hope, and we want to try to redose patients that previously received gene therapy, how can we do this safely and effectively by potentially using different ways of immunomodulation? And then huge questions still remain around how we're going to afford this therapy as a society. It's an over $3 million one-time treatment. And in general, in the gene therapy field, this is a huge area that needs to be focused on. Next slide. So while I've been highlighting the sort of the ones that made it, the ones that received FDA approval and met that sort of benchmark, there have been many, many trials in DMD. There have been many different sort of targets explored, many of which have not sort of made it to full approval in clinical applications. Next slide. Next slide. But I think we both would agree that we remain very optimistic about the sort of the research development in DMD. While we have amazing treatments, there's still a lot of work to do, because there's still very symptomatic boys with DMD, and so the work is not over. Next slide. So when we look at what we're all still in development, what we're working on, as I mentioned, still modifications to the AAV-based gene therapy products, ones in development. How can we make the ones that we already have better? There are next generation exon skipping agents that are in development that have modifications to them to help improve the delivery to muscle and the stabilization of that product, so that hopefully dosing administration can be less frequent for patients. Can we be more targeted or specific in our immunotherapy, as opposed to the broad sort of effect of steroids, to reduce that inflammation and interrupt that dystrophic process? There are cell therapies being explored for both skeletal and cardiac myofiber restoration, and then various small molecules in development to improve sort of muscle contractility, strength, stability, likely to be add-on therapies to some of the things we've already discussed. But as it's hopefully been clear, these treatments have greatly improved symptoms for patients, but there's still room for more improvement.
Thank you so much for your time.